Welcome, everybody. You are attending the mini SIPS administration tips training about kind of real world implementation of the mini SIPS. And we'll go through some of these things that you might encounter in your everyday setting in terms of how to administer, as well as kind of how to handle tricky cases. My name is Dr. Sabrina Ereshefsky. I have almost completed my clinical psychology licensing. I have many roles across the EPI-CAL and TTA, but I also hold a role in our UC Davis early psychosis clinic as a trainer and supervisor, and I lead up our assessment and intake sections of our clinic. Today's learning objectives, we'll be practicing and learning a range of administration prompts using the qualifiers to probe yes endorsements to mini SIPS items. You'll learn the important time points for the mini SIPS. So when did an individual first reach their attenuated level symptoms? Have they ever reached threshold level symptoms? What's their current or past month presentation like? And then we'll learn a couple of strategies to navigate real world client presentations. One of the main prerequisites for today's training is just any SIPS training or use, but really most of you have probably attended our last month's mini SIPS training with Dr. Tully, as well as these other components that are available on Canvas and through the weekly assessment consultation groups as part of the TTA. And so just jumping in, I know you all may not have completed all aspects of intake training yet, but I just want to remind you that the mini SIPS kind of fits in with these other measures administered at intake. And so it's important to use all of the information available to you that we collect about functioning and mood and trauma and substance use, as these can provide context to help you determine if psychosis experiences are better explained by other diagnoses, help determine the overlap and onset of symptoms within an individual's timeline, as well as helps you kind of differentiate some of those attenuated versus threshold symptoms versus whether something falls within normal limits. And so if you have done our mini SIPS training, you must have learned a lot at this point. The training may have been accompanied by feelings of being overwhelmed if this is a new tool for you. And I just want to validate your experience and say, hang in there. You don't have to memorize any of the things we go through today. You have all these materials to always reference back to. And I just want to reinforce the SIPS in general was developed as a research tool. And part of our training last month was very heavy on background and heavy on details. But because we're using the mini SIPS in this clinical setting and for slightly different purposes than research, which for us is eligibility and appropriateness for our clinics, we want to reinforce and highlight some additional concepts and practices specific for our early psychosis clinics. So first, it's important to remember the sources of information that can contribute to a rating. From your interview, you get your client report, but you also get things like nonverbal behavior. From family and primary support persons, they can also contribute their perspectives. And we really greatly encourage these individuals to attend the intake. We want you to gather information from current providers, so it may be important to connect with them before or after the intake. And you also want to request important records and carefully review them and integrate them with everything you're learning. Along with the other trainings that you'll receive soon, make sure to incorporate the client's culture or subculture to determine whether their psychosis symptoms occur within or outside of cultural norms. And in today's training, we also have a couple of questions that you can use to probe that kind of information. I review all of this information with you for a really important reason. You should not be making a rating on an item that a client does not endorse themselves. So if information is provided only by a collateral or a record, you should be careful to use that information to provide context and to document these experiences, but it should not be the sole source of your mini SIPS rating. Be careful as well, though, if a client endorses a symptom but is maybe just more reticent or has difficulties with memory or disorganized communication, you should be using those sources of information to determine severity. And this can be also helpful if there's noticeable changes in behaviors or functioning. For each individual item endorsed, and so we have the 3 different sections on the mini SIPS, the delusion-like symptoms, the hallucination-like symptoms, and the disorganized symptoms. We want you to ask each of these elements so that you can make an accurate rating. So for any endorsed item, and these areas are onset, frequency, duration, conviction, distress, behavior change, and impairment or interference with functioning and in your life, as well as change over time or worsening. Another goal is to get a good understanding of these different time points. So the onset, when did these symptoms first start? Was there a point where this worsened? What has been the highest level that the symptom has reached? And what is the current level of the symptom? What's going on in this past month? And so for each endorsed item, we want to try to get an estimate of where that's falling. If there's more than one experience endorsed in an answer, we want to assess whether these are unique or connected, as symptoms can sometimes change over time. So for example, if a client endorses more than one type of visual perceptual abnormality or hallucination, they may sometimes be rated the same or separately. So it just depends. So say someone is seeing a shadowy figure versus seeing another type of visual stimuli of an oozy substance dripping from the walls. These are qualitatively different experiences, even though they come from the same sensory system. Alternatively, if they see a shadowy figure and then 3 months later, the figure acquires more specific human features, like eyes, clothes, and this might be considered the same symptom and should be rated as a worsening and as the same item. So we want to find out how their experience changed. Are they more distressed now? Are they changing their behavior more? Is it interfering more with their functioning? To get a better idea of the types of questions that you should ask after each endorsed item, we've created a list of helpful follow-up questions and specific ways that you can operationalize and make these metrics a little bit more concrete, especially for things like frequency, duration, distress, and conviction. It's also important to remember, if you're getting the gist that the item does not really cross into this risk range, meaning maybe staying within the normal limits, you don't need to ask all of these follow-up questions. Just make sure you get enough information to understand the individual's experience before moving on. I'll just plug a caveat though. As you're learning, it may be helpful to ask more questions to be sure you're fully understanding the individual's experience. So starting with some of our list, you might want to consider asking one question from each of our different categories that you'll see over the next few slides. One of the first ones that we want to do is just ask them some more open-ended questions to get more information about the symptom. So tell me more about that. Can you give me an example of when this happened? That's usually really helpful to better understanding whether you want to keep proceeding with asking more questions or whether you can move on. I've included here a set of kind of things that you can probe for or ask about for some categories of like auditory and visual perceptual abnormalities or hallucinations. And so you can come back and reference this list for important cues that you can look at for like that quality, quantitative differences with those experiences. We also want to ask about onset. So when was the first time you had this experience? When did you first notice this happening? Trying to anchor them to some different activities on their timeline that we have some examples of later on. So you want to ask, is this maybe around a season or a time, a semester in school or a holiday or a birthday? That can help to anchor them. Wanting to find out kind of what else was going on around this time of that individual's life. To get at frequency, we want to ask, how often does it happen? And for duration, when you have this experience, how long does it last? If the client doesn't give you a specific number for frequency or duration, that sometimes or every once in a while, uses vague language, you can prompt them with offering them a few options to help them narrow down their experience, making sure that the options vary so you're not really leading them on. So for frequency, offering them, does it happen one time a month, one time a week? Is it daily? Is it multiple times a day? And then for duration, is this lasting seconds or minutes or hours or days even? We also here want to find out, is this still happening? So was it happening this past month? So asking that for frequency and duration as well. We also want to know maybe when it last happened, if it hasn't happened this past month. So a couple of different probes and prompts that you can come back to. Preoccupation is an interesting concept that isn't always covered on the mini SIPS, but it's something that counts towards frequency and duration. And so you can use this metric to kind of differentiate the time that an individual is in the experience versus how much time they're maybe thinking about the experience or distracted by it. And so that can help with us better identifying how impactful this is for them. So were they able to switch their attention to other things, or did it stop you from what you were doing? How much time did you spend thinking about X, Y, or Z symptom? Distress is another really important area for our mini SIPS. And we have learned in our past psychosis trainings that distress is an important concept, especially in differentiating between psychosis-like experiences that fall within the normal range versus those that fall within the attenuated range. So we're really not trying to pathologize individuals who have experiences that are psychosis-like. But when someone is having an experience that is very distressing, is changing their behaviors, impacting their functioning, then this is when we're starting to perk our ears a little bit more, trying to better understand how this is impacting them. And so distress, we want to try to get at in a qualitative, but also kind of concrete way. So what is this experience like for you? How much does this bother or distress you? And we really want to try to get at their experience on this 0 to 10 scale. Can they rate this? And I have an example here of on a 0 to 10 scale, where 0 is you're not bothered or distressed at all, to 10 is the most bothered or distressed you can imagine. Where do you fall when this first started, or when it was at its worst, or in the past month? And we want to offer them these anchors for these different scales as many times as they need as we're asking these questions. And you can kind of get a feel for whether they understand the scale, that you don't have to offer it anymore. We want to also get an idea of the impact and the effect and interference on an individual's life. So this is kind of getting at our impact on behavior and functioning. Did they do anything differently because of this experience? How did the experience impact how they went about their day? Did they do anything in response to the experience? Does having the experience ever cause you to do anything differently? You can see there's like multiple iterations of the same type of question. You can just get a feel for what is the best one for you and kind of have that in your pocket as you're asking these questions. And then we also want to ask things about kind of the functional interference. Have these experiences interfered with your everyday activities? What about with work and school? Does it impact your relationships? Part of functioning can also be impact on like concentration or sleeping. So you want to try to see if those things are having some interference as well. Part of the effect on behavior is also this idea of disclosure. So you can ask someone, did you tell anyone about this experience? Did other people notice? And this can be a helpful place to get feedback from collateral, because we can have some of these like observed behavioral manifestations that sometimes individuals aren't as aware of. And so are we able to connect them with a specific experience that someone's endorsing? Conviction and meaning making is another really important concept in our mini SIPS. Within meaning making, it's about how is this person understanding this experience? How do they explain it? What do they account for it? Does it have a meaning to them? And what do they believe? In conviction, we're trying to find out how real or true they feel this experience is. And so we want to find out what their experience was in the moment while it was happening, as well as when they look back and reflect back, what do they think about this? Maybe they have a little bit more doubt about it. And so we're trying to get at, is this their mind playing tricks on them, or is this something they hold on to so tightly that no one can convince them otherwise? And so we want to try to get some of the qualitative kind of open-ended questions, but we also want to ask some of these more operationalized kind of numeric answers. So can we get a rating on a scale of 0 to 10? And so for a hallucination-like symptom, we can ask on a scale of 0 to 10, where 0 means my ears are definitely playing tricks on me, to 10 means I was fully convinced that I heard the voice through my ears, and asking them, where do they fall? And so this can be a really important time point to find out, is this person have any doubt that can be induced into their experience? And this is important for differentiating between our risk state and our threshold psychosis. So will they take the line? Will they say, maybe I do have some doubt, maybe it is my mind playing tricks on me? So even if in the moment they're saying, I was fully convinced. So trying to get a little bit of that nuance in their experience. And then the last few sections we have here, we're trying to define change and worsening. It's kind of hard sometimes to operationalize. So we want to try to get at what is their understanding? Has the experience changed over time in any way? And was there a time when this got better or worse, right? We want to better understand the experiences. So this can be in frequency or duration or intensity or distress or conviction or the change in their behavior functioning areas. And, with our differential diagnosis, we also want to try to understand, does it get better or worse with different mood symptoms when an individual is in a depressed state or when they're in a manic state? Do the symptoms kind of go along with them? We get referrals for individuals to our programs from many different backgrounds, and we come into our interactions with them and assessments with them with cultural humility and openness to learn about the individual and the family's experience. And so we want to better understand whether an individual's experiences kind of fall within the norms for their age and culture and even subcultures. And so we want to ask them specifically, what do your family or friends say when you talk about this experience? Do your family or friends have the same beliefs or talk about it to the same extent that you do? Lots of examples have come up in prior trainings about belief in ghosts or spirits. And this can sometimes fall within a family or someone's belief set, but other times it can fall outside of it and be really distressing or interfering. And so it's our responsibility to ask questions to determine these experiences and characterize them appropriately. This is also another really important place that we can pull in collateral and ask them about their culture and do they share the same belief as the individual who's sharing the experience, and to the same extent. I think that's another really important differentiation. So I just want to open up to our group here. What other questions might you ask? I know I just gave you a very long list of questions, and I'm just curious, what other things might you be thinking about as you're administering the mini SIPs?
When you brought up the conviction, because I noticed that you mentioned what was your experience when it happened and what do you think of it now. And a lot of times those are very different. Like the 2020 looking back, they're like, yeah, I think it was my mind playing tricks on me, but at the moment I was really scared. So which one do we go with? Because that's pretty different.
Absolutely. And that's where, as I was mentioning, it's important to get at these time points. So when it first started, what was it like? What was it like at its, worst, at the highest point? And has it ever crossed into that threshold psychosis area versus where are they now? Those are all, they can all be rated differently. And we want to kind of characterize the symptom across time in that way. And so it's really important. What do you, when you're hearing this from an individual, would you be concerned that they crossed over into the threshold psychosis space at that 2020 time?
I mean, when I hear that they were scared when it happened, that makes me think they had a 100% conviction that it was a real threat on some level. But I guess then you'd have to look at the timeline. Did that happen within the past month, or was that a year ago when they first had it happen? Because then that would change, like if they're in the normal range now, looking back on it, and then they wouldn't be in attenuated symptoms anymore. Am I right there? Or would I be looking at the most severe symptoms? And if, yeah, I guess the whole thing is most severe symptoms, and if it's in the past month for attenuated, or did they reach psychosis level threshold when they were having it a year ago, I guess.
Right. And I think, it's different for everybody, and we're kind of, people can be kind of have their symptoms remitted by the time you see them. And, that's good to characterize. But we do want to assess that time point of when things were the worst. And, distress is one piece of it. It doesn't always necessarily translate to the conviction piece. So it's important to ask that other question about, in the moment, was there anything that could convince them otherwise that this experience was not happening, either the delusional conviction or whether they were seeing the shadow in front of, or the person in front of them as clear as I can see them today, or they could hear the voice as clear as I could hear them now, and nothing could convince them otherwise. So we want to be able to get at where they were at the time of that heightened symptom, and does it cross over into that threshold psychosis space or not? And then, for treatment prognosis and for treatment planning, we would want to know where they're at today too, and in the past month, so that we can kind of come up with the best plan. In case you forget these qualifiers, there is a qualifier section on each page of the mini SIPS. So soon enough, though, you'll be getting a hang of these and you'll be relying on them less and less. For now, though, just remember you have the tools you need at your fingertips. Just getting to the final bits about rating, we want to rate these experiences. We want to rate the most severe item within each of the domains. So delusion-like symptoms, hallucination-like symptoms, and disorganized communication. And we can do this, based on what the clinic tells us, taking everything that we have at our disposal into account, including collateral. We sometimes need to use our clinical judgment here. And we need to also put that all in context of what's normative for the client's age and culture. So here are, some of the screenshots from the mini SIPS, the rating page. So we have the delusion-like symptoms, which covers the unusual thought content, suspiciousness, and grandiosity, and has these examples of what might be considered in the normal range, attenuated range, and psychotic range, knowing that these boxes don't fit each person's experience exactly. And so that's where some of that clinical judgment and this training can be helpful, and the types of questions that you need to ask to differentiate some of these different levels of severity. Within the hallucination-like symptoms, remember we're covering all the different sensory systems, with auditory and visual typically being the most commonly experienced, but it can impact any of the different sensory experiences. And again, some examples here about what it might be like to experience a normal range, attenuated range, and a psychotic range experience. And then within the disorganized communication, this covers odd speech and focused speech, meandering speech, and again, what is that differentiation point between normal and attenuated, and between attenuated and psychotic? And sometimes for communication, having the structure and leading structure in place, and yet an individual is not able to really follow the flow of the conversation, you start to really feel the weight of the difficulty with understanding a person when they're kind of within this threshold psychosis range. Some of the take homes here, kind of getting at the gist of what each of these levels means. Within that normal range generally means a brief but maybe puzzling experience, but without that distress or behavior change or impairment or conviction. In the attenuated range, there may be some type of behavior change. Are they avoiding places or people, or isolating more, or doing these checking behaviors, talking to others about their symptoms? There may be functional changes. Are they now getting into arguments with family? Are they able to keep up in school or at work? Or are they distressed about this experience? And then getting into this, whether they cross over into the threshold psychosis range, we're really looking for that change in degree of conviction. If they are asked about the symptom and you ask, do you think it could maybe be in your mind? They could maybe respond, oh yeah, maybe it's in my mind playing tricks on me. That would drop them into the attenuated range. If they are 100% sure that what they believe or saw was really there, you don't have any doubt, like I had been saying, I want to hammer this in. No one can convince them otherwise in the moment or after. They may be moving into this threshold range. Beyond what's used in the severity, kind of intensity rating anchors, it's also important to remember that the mini SIPS has these other tools at the end to help you with identifying whether someone falls within an attenuated psychosis risk syndrome versus a threshold psychosis diagnosis. So the severity versus the diagnosis, we're differentiating here now. For someone to meet this threshold for attenuated symptoms, the symptom has to occur for at least one time per week and have onset or worsening within the past year. For full threshold symptoms ever in their life, they should have experienced the symptom for at least 1 hour a day at an average frequency of 4 days per week over a 1 month. And you can see some of these things may be a little bit inexact, at times to try to collect and, who made these criteria at the time, is really a difficult thing to say that this is exact and going to help differentiate. But these are the metrics that we go by right now. And so the best of your ability to be able to assess where an individual is falling can be helpful here. There's also a tool at the end of the mini SIPS that prompts you to consider whether symptoms might be accounted for by or other diagnoses, and we'll get to that in just a second. And so here you can see in these different boxes, these are just little screen grabs from the mini SIPS, the areas where it prompts you to think about these different frequency, duration, and worsening change criteria. And those are especially important for appropriateness and eligibility sometimes too. Here we have the tool that can help with discussion for differential diagnosis. In future trainings where you'll be learning a little bit more about the SCID, you'll be getting a little bit more of a bulk about differential diagnosis. But it's important that while you're learning to keep in mind whether the experience the individual has could be described as being better accounted for by something else. An experience, clients that I see sometimes, someone says that they've been isolating away from others because they don't feel comfortable around them. You may need to ask the individual, are they experiencing something like social anxiety? And it can be helpful to ask some of those core questions, like, do they feel they may be judged or embarrassed if they did something in front of peers versus if they're worried that others will do harm to them? So some of those specific questions can help with differentiating. And you'll be getting some more helpful tips during our SCID trainings. In terms of how we use this information at our early psychosis clinics, eligibility criteria can vary from clinic to clinic. So there may be differences in whether you accept individuals with primary affective disorders, so like major depression or bipolar with psychotic features, or individuals with substance-induced psychosis diagnosis, and whether you accept individuals with attenuated psychosis versus only full threshold psychosis, or attenuated psychosis that has only had worsening over the past year versus had been present longer. And so those are decisions that are made kind of in the leadership level, but should be eligibility criteria that your team should be discussing. One thing though that is pretty typical across many clinics across the US is having set a duration of untreated psychosis. Oftentimes this is set at 2 years, but it also can vary clinic to clinic. So being aware of that. And so that's the amount of time that it's been since an individual has reached that full threshold psychosis level. So with Yana's example, she was referencing back to a client in 2020 maybe, and has it been more than 2 years since they reached their full threshold symptoms versus whether maybe they didn't reach threshold at that time, and so they're still eligible. The client's appropriateness for the clinic might also not be clear cut because we also need to make a determination about the level of care and the type of care an individual needs. And these types of decisions take place within team-based conversations at kind of all stages. So in weekly assessment consultation or following intake write-ups or team meeting and case conference or supervision. And this is kind of what makes CSE programs special. You're not alone in these decision-making processes, and you can raise questions at any point along the process. So don't hesitate to speak up at team meetings. You being the primary intake assessor, I'm guessing you being here today, will have the most information on the individual that you're assessing and should advocate for what's best for the client. It's not always black and white, but it should always be client-driven approach. Figuring out the level of care needed can also go in multiple directions. So do they need a higher level of care or a lower level of care? And, this can mean like who's available on your team to provide support. Do they need more crisis level care or 24-hour care? And so those again can be decisions that are appropriate for your team to discuss. Also for the lower level care, we have limited resources at our specialty clinics. And so if an individual's symptoms kind of don't reach a threshold that is needed to offer these services in our clinic, then it's sometimes better for them to stay in the other community clinics that treat their other general symptoms. So if they have clinical high-risk symptoms that haven't worsened over the past year, it might be okay for them to stay in that community clinic. There's also times when psychosis symptoms may not be the primary target for treatment, or maybe a different modality of treatment may be appropriate. And so again, these different conversations about comorbidities should be discussed at your team level. Okay. All right, with our last minutes, I want to switch focus and talk a little bit more about kind of some of these real world examples and challenges that you might encounter. First, I want though to plug some ideas about priorities. So you're collecting so much information during these intake assessments, and you really need to keep in mind that one of your top priorities is about this eligibility and appropriateness criteria. You want to get enough information to also understand the onset dates for these attenuated and psychosis threshold symptoms, so that the duration of untreated psychosis being an eligibility criteria. And then another goal is getting an accurate diagnosis, but it's not necessarily the top goal. It's okay if you don't have all the answers and you need more time to come up with a more comprehensive diagnosis. It takes practice to get comfortable completing these assessments. So just have open conversations with your supervisors or team consultants about your training needs so you can continue to learn and improve. Next up, I just want to go into some different presentations that you may encounter and maybe offer some helpful strategies to increase your success in your interviews. So I have these kind of just prompt questions. So what do you do if someone is really concrete or very quiet? You want to try asking questions differently. Sometimes this might mean simplifying the question or trying to rephrase the question using different terms that may be more understandable. Checking in for understanding with the question stem itself or with the response that they're providing, to ask if they understand all the words in the question. Do they need clarification with a specific word? And then can you restate their response in your own words and ask if you are understanding what they're saying? Examples can be really helpful here. If you think they may not understand the question, you can ask them to provide an example from their own life, preferably. But if someone needs to get really basic, just ask them to provide a more general example, enough to really gauge their understanding. You, as the assessor, can also offer a few examples of a behavior that you're trying to assess. So someone asks about if you can predict the future as one of the mini SIPS questions, making sure that they're understanding. Make sure to provide them with a few examples of the behavior, but make sure it doesn't inadvertently bias their answer. So giving more than one example can be helpful. If appropriate, if someone's really concrete, you can use other means to help illustrate ideas and thoughts, in writing or in drawing. So using multiple modalities to help support their understanding. Sometimes it's really necessary to heavily rely on collateral to help convey questions to the client, and that's okay. You do what you have to do to gather as much information as possible, given the constraint of situation. So it's okay. Learning some of these different strategies can be helpful. What do you do if someone is disorganized or a poor historian? Individuals who present like this often are on the more severe side of the threshold psychosis continuum. And so working with more structure can be helpful for you. Even with your best efforts, though, with someone who's more disorganized or tangential, you may not be able to focus them and get the information you need. And so that's okay. I just want to assure you, just do your best. Here, you can try your best to ask clear and simple questions, refraining from complex sentences or multi-part questions. Be direct, repeat questions, provide prompts to help the client stay on track, or restate the client's response in your own words to ensure understanding. If they're really disorganized, offering short breaks can help individuals stay focused for shorter periods of time. And if they have a hard time, really try to use some of those anchoring dates on a timeline. And so here we have some other examples of what those could be. What if someone is a talker, tangential? It's good practice at the start of your interview to let them know we'll be working together for X amount of hours. If I interrupt you, it's not because I'm being rude, but I want to respect your time as we have a lot of questions to get through. And so with you having given that caveat, it's okay to interrupt and redirect them to the question. So some examples, I'm not sure I follow. How is this incident related to your suspiciousness? Empathizing with them, validating them, and then redirecting them. That sounds really tough. Thinking back to my question, highlighting the time constraints here, noting that you need to move on. We only have X amount of time left, and we have a lot of questions still to get through. So going back to my question, don't be afraid to be a little awkward and abrupt when cutting in to redirect individuals. So it's okay. And again, you're just doing your best in the moment. So what do you do if someone endorses everything? First, I just want to normalize. It's not possible to always get through everything. So you will need to prioritize areas of the intake to get the most pressing information. If you're a team that uses a phone screen as a guide for your assessment, this can help you highlight areas of primary concern or areas where you need to clarify. You can go with the flow. If clients endorse something that you will ask later, you can gather that information in the moment and then return to where you were before, but make sure you don't lose your place and you note the item to come back to. And if you're trying to differentiate symptoms from one another because they're all kind of flowing together, you may need to try to separate out thoughts and beliefs from experiences. And so this is where that meaning making kind of comes in those conviction questions. So if someone is describing a hallucination, but their meaning making of it is in the delusional content, so it's part of an unusual belief or maybe suspiciousness, we're trying to better understand and tease apart those experiences. So this is oftentimes, more prevalent in individuals with first episode psychosis who have a more crystallized delusional framework where all their symptoms tie together to inform their experience. And so again, when we're asking our qualifier questions, we want to anchor individuals to the specific prompt that we're getting those qualifiers for. So if we're hearing voices, for instance, I want to get the frequency and duration and conviction distress specifically about the voice. But then I also want to get the qualifier responses for the meaning making. So they think the voice is an external entity who's trying to control them. And so you want to get all these different qualifiers to better understand the intensity and severity of that delusional meaning making of that experience. Again, I know you all may have not done SCID training yet. And so this slide could be helpful maybe in the future to really get down your DSM criteria, really understanding what are the most critical inclusion criteria for these different diagnoses that are helpful for differential, where you need to follow up more for assessment. And again, coming back to the idea that the purpose of the assessment is eligibility and not necessarily identifying all possible diagnoses. With someone who's endorsing everything, again, your time constraints may be more prevalent. And so what else needs to be completed? What do you need to prioritize with the time you have left? Maybe even reaching out to your team lead or a supervisor to help you with that prioritization. If you are not able to get to all your questions and have the most comprehensive assessment that you had hoped for, don't fret. Again, it's helpful to know what areas do I need to follow up on in the future. So for someone who has substance-induced psychosis, we may not know if it's substance-induced versus a primary psychosis diagnosis if they haven't stopped using substances for long enough. And so that might be an item that you have for a rule-out diagnosis and might need to be followed over time as maybe they cut down on substances or stop substance use entirely and have that kind of washout period to see if symptoms are still present. Also, if your team has the structure where you have a two-part intake where a clinician does one part of the intake and then a psychiatrist does another part, you can always give the psychiatrist or the other individuals who are doing the second part, some ideas and prompts of areas that you weren't able to cover and see if they are able to cover that in their part of the intake. And then I just have a couple of helpful tips here that I'm not necessarily going to go into, but you can come back to. You're going to have a lot of information, as I said, a lot of sources of information for your intakes from the interview, collateral, maybe from records, from a phone screen if you have that. And sometimes this information can be inconsistent. And so how do you resolve these pieces? It's important to state the source of the information if you're doing a write-up, as well as note if you were able to ask about an inconsistency during the interview itself. If there's conflict or discrepant reporting with the client and the collateral, if you have them both in the room, it can be helpful to try to separate them during an intake. So depending on the age of the individual, starting off with someone, the parent, or starting off with the client themselves, and then following up with specific questions, and then bringing them all together at the end with kind of providing what's next so that you can kind of separate some of the arguing, irritability. Maybe the parent or the client is minimizing in front of the other. So you just want to be really aware of those different things. Again, these instruments are being used together. So we have the mini SIPS. Most of you maybe have completed the global functioning training, and then the SKID training is kind of upcoming, but you are really kind of coming together to best understand those priorities. So the duration of untreated psychosis, the dates that are important. So when did symptoms start? When have they worsened or been their worst? And how have they been doing in the past month? For those SKIDs that you're going to be targeting for diagnostic clarification and eligibility, you'll be learning a lot more about the time frame. So how do the psychosis symptoms and maybe depression overlap or not overlap? And that'll help you with identifying whether you have an individual with maybe schizoaffective disorder, depressed type, or major depressive disorder with psychotic features. And so these will all be really important pieces that you're going to start to put together as part of this puzzle of your intake training. So lastly, I have a couple of examples of timelines that I've started to create for a client following an intake to help me with better understanding the overlap of symptoms and helping me with maybe identifying if I have holes still that I need to help get answered. So I have here one example with an Excel sheet, and then another one with a Word document using kind of a color coding, different ways to visually see the overlap of symptoms, what could be the etiology of something. So for this individual, they had a lot of trauma at the early start of life, and then their psychiatric symptoms started. So that helps with a little bit of the context piece here. You just need to find what works best for you, whatever method that is, and try to see if you can find tools that you can continue to use with consistency. So some final takeaways. A lot of this is about practice and repetition. So if you're still feeling kind of unsure about the mini SIPS, maybe find a colleague to practice or role play with. And I know with the individuals who are part of the TTA weekly assessment consultation groups, there will be some opportunities for that. Don't be shy about asking questions or getting clarification as well from any of us at the TTA. Remember, we're here to consult. The client isn't familiar with the SIPS, the mini SIPS questions you're about to ask, and so they don't know if you mess up. So really just always give yourself grace as you're learning and just want to say you got this.